Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation. Today we are going to talk about an article, Greatest Percentage Involved Core Length and Risk of Clinically Significant Prostate-Specific Antigen Failure After Radical Prostatectomy. We all know that after radical prostatectomy, many patients, some say 30%, some say 50%, they have recurrent PSA rising. But it's very important to find prognostic factors to tell us which PSA rise will be associated with significant morbidity or even mortality for the patient. We all use sophisticated high-tech markers, but we forget to look at the low-tech information that we get from the biopsy material itself. And here is a paper published in the Clinical Genitourinary Cancer in March this year. The name of the article is Greatest Percentage Involved Core Length. It means they measure the length of the cancer in the core. And what is the risk of clinically significant PSA failure? Clinically significant, not just having a PSA. I could tell you a secret that clinically significant PSA was found to be any PSA doubling time which is shorter than 10 months. And that relates to the issue of failure of radical prostatectomy. When we look here at the list of researchers, we are all familiar with Dr. D'Amico from Harvard. Let's look now at the author information. So we see this is the Harvard Radiation Oncology Program, Department of Radiation Oncology. We see here the Department of Statistics. We see here the Department of Radiation Oncology and also the Department of Urology. Let's look now at the abstract. Background. Radical prostatectomy can cure men with unfavorable intermediate or high-risk prostate cancer. That's true especially in patients that have low volume but high-risk disease. However, some will experience short prostate-specific antigen doubling time, I mentioned the less than 10 months, that requires additional treatment with increased toxicity. But it may be justified to add the additional treatment if indeed we have a signal that this patient have worse prognosis. The present study investigated whether the greatest percentage of involved biopsy core length, this is what GPC stands for, greatest percentage of involved biopsy core length. So they look at the core of the biopsy itself, whether it can preoperatively identify men at risk of short PSA doubling time. And again, that feared short doubling time is less than 10 months. Let's look at the patient and method. Patient and method. A total of 503 men with biopsy proven they underwent radical prostatectomy in one academic institution from January 2005 till December 2008. The men that were excluded were men with incomplete pathologic information, those who received neoadjuvant or adjuvant hormonal therapy or chemotherapy, and those who had undergone adjuvant radiation therapy were excluded from this study. The median follow-up of the study, this is important, was 4.89 years. A competing risk regression was used to assess whether an increased GPC value was associated with increased PSA doubling time of less than 10 months. They adjusted for age, percentage of positive biopsy result, and age group. So let's look at the results. The results of the 402 men, 34, 8.46%, developed PSA failure. 50% of them had a PSA doubling time of less than 10 months. That means that 17 men, or 4.5% or so, they developed failure of PSA that was significant, because having doubling time less than 10 months, that's a bad prognosis that predicts suffering from disease, having morbidity, or dying from the disease. An increasing GPC value was significantly associated with increase, like we said. Men with GPC more than 30% versus those with less than 30%, they had significantly greater incidence of bad PSA recurrence data of less than 10 months. So that means the men that were found to have more cancer in the core of the biopsy there, it is more likely that after the radical prostatectomy, those will be those that will fail, because there, even within 5 years, will show that their PSA doubling time will be less than 10 months, and that by itself will predict a clinical failure, not just PSA failure. So the conclusion: men planning to undergo radical prostatectomy for unfavorable intermediate or high-risk PC with GPC of more than 30% should be considered for randomized trial evaluating the effect on survival of neoadjuvant use of treatment that extends survival in those with castrate-resistant metastatic PC. Well, you have to understand, this is an academic institution, and they look at, here we have a criteria that we could use to generate studies and divide the group between those that had high GPC versus those that have low GPC. But for us as clinicians and for us as patients, the reason this is important is because when we have to make a decision whether to do radical prostatectomy or not, and we have to decide, for example, to do active surveillance or not, we look at the Gleason, we look at the PSA, we look at other factors. But if we add this factor by itself, the length of cancer in the cores of the biopsy, we have an additional information here that may sway us one way or another. Maybe we'll feel better if the GPC is less than 30%, then we know the likelihood to develop PSA doubling time, the bad one, the less than 10 months within 5 years, is 0. But if those patients have GPC more than 30%, then after radical prostatectomy, their likelihood to develop within 5 years is 30%. So we have here 30% versus 0% in 5 years for patients that have different length of tumor in the biopsy core. And that raises the question, what should we do with these men that have worse prognosis to develop this significant PSA after radical? What should we do with those? For those that have good prognosis, we may say maybe you could even do active surveillance. For those that have more aggressive prognostic finding on the GPC, we need to consider whether to give them additional treatment together with the radical prostatectomy, or perhaps after the radical prostatectomy, not even wait for the doubling time to show itself, but give earlier treatment. And if the margins are positive, then for sure, perhaps to give radiation earlier, neoadjuvant, and not a salvage to wait later. And that may change also our decision, trigger how quickly we want to add in treatment after the radical prostatectomy, when the question is how long to wait. So this simple criteria of GPC, of showing the length of cancer in the biopsy core, it's a low-tech piece of information. It's not a sophisticated genetic testing of the tumor. And I think, although we get very excited about the high-tech, we should go back to the roots of the low-tech and use it also in order to help us to make decisions how to best take care of our patient. If you have any question, don't hesitate and write to us to info, abbreviation of information, at pcref.org, and I spelled it for you, or 619-906-4700, or even, if you are brave enough, get on our website homepage, www.pcref.org, and there is a segment there where you could click and ask your question by sending a video. If you have a video camera on your computer, a webcam, then you will be able to click, record your question, and then click and send us your question. Stay well, stay informed, keep stalling, and have good time. Bye-bye.